Mounjaro and diabetes care. Common questions, explained in diagrams. From clinical trial data to everyday habits, a new shape of treatment, learned in Q&A form.
In this video, I'll be putting a patient's playing questions to the doctor. Thank you for having me. Doctor. What are incretins, the hormones that lower blood sugar? And how is Mounjaro different?
Incretins are hormones released from the small intestine when you eat. Mounjaro acts on two of them at the same time, GIP and GLP-1. That is what makes it a new dual incretin. The diagram on the left is how earlier drugs worked. GLP-1, released from the small intestine, reaches the pancreas. It prompts insulin secretion when blood sugar is high, and it curbs appetite. It comes from the L cells of the small intestine. On the right is Mounjaro. On top of GLP-1, it also acts on GIP, which is released from the K cells of the small intestine. GIP further supports blood sugar control, and it may also play a part in reducing fat. When the two come together, the push on the pancreas and the control of appetite in the brain strengthen at the same time. That is the synergy shown in the diagram. Mounjaro, generic name tirzepatide, uses that synergy to deliver stronger glucose lowering and appetite suppression than either hormone alone.
How has Mounjaro's efficacy been proven?
Through the SURPASS program, large-scale global clinical trials that tested it rigorously under a wide range of conditions. Let us follow the trials in order. SURPASS 1 compared it with placebo, a dummy drug. SURPASS 2 was a head-to-head comparison with Ozempic. SURPASS 3 and 4 compared it with insulin, Tresiba and Lantus. SURPASS 5 looked at what happens when it is added to existing insulin therapy. And in Japan, J-mono and J-combo. Those tested it separately in Japanese patients, on its own and alongside other drugs.
What about efficacy in Japanese patients, and use alongside other drugs?
Both on its own and in combination, it delivers strong hemoglobin A1C reduction and weight loss. The graph on the left shows how hemoglobin A1C moved. In the J-mono trial, it fell sharply within 12 weeks of starting, and by week 24 it reached an average below 6%. The right is body weight. In the J-combo trial, at week 52 the average drop was between 5.8 and 10.7 kilograms. The higher the dose, the larger the reduction tended to be. And then the risk of complications. The chance of reaching a hemoglobin A1C below 5.7%, the same level as someone without diabetes, reached as high as 71%.
Those are strikingly large numbers.
They are. But these are trial-wide averages and attainment rates. Even on the same treatment, how well it works always varies from person to person. Set your own target with your doctor.
Compared with insulin Tresiba, or with Ozempic, what sets it apart?
It is powerful for both glucose control and weight loss. But gastrointestinal symptoms need watching. Let us read across the table. For hemoglobin A1C reduction, Mounjaro is very strong. Even 5 mg beat Ozempic at 1 mg. Ozempic and Tresiba are both strong as well. The effect on weight divides sharply. Mounjaro, a large reduction. Ozempic, a moderate reduction. Tresiba insulin tends to add weight. The risk of hypoglycemia is low with both Mounjaro and Ozempic. With insulin it is high, and the dose has to be adjusted. The main side effects, gastrointestinal symptoms for Mounjaro and Ozempic. With Mounjaro they show up especially when the dose is being escalated. With insulin, it is weight gain and low blood sugar.
Can it be used by someone already on insulin therapy?
Yes. Used together, it may cut the amount of insulin needed while dramatically improving blood sugar. These are results from SURPASS-5. About 62.4% of the group on 15 mg reached a hemoglobin A1C of 5.7% or below, the level of a person without diabetes. The insulin dose came down too. Requirements fell by roughly 10 to 20%, and the results suggest injections may even become unnecessary. On the left of the diagram is insulin on its own. Insulin normally works to add weight. Add Mounjaro, and you get the picture on the right, a weight loss of 5.4 to 8.8 kilograms. It covers insulin's weak point.
Beyond lowering blood sugar, does it benefit the organs?
Through lower blood pressure and anti-inflammatory action, it is expected to protect the heart and the kidneys, what is called cardiorenal protection. The kidneys first. In the SURPASS-4 trial, the risk of kidney function declining was reduced by about 40%. It also held down the appearance of albuminuria, protein in the urine. For the heart, lowering blood pressure, together with antioxidant and anti-inflammatory effects, shields the cells from damage. It is especially recommended for people with a history of angina or myocardial infarction. For them, active use is encouraged.
Does it work as an obesity drug as well?
In patients who have both type 2 diabetes and obesity, large weight reductions have been reported. But Japan's regulatory framework calls for care. The data is compelling. In the SURMOUNT-2 trial, 15 mg produced a body weight change of -14.7%. About 80% of participants lost 5% or more. Compared with Wegovy, Mounjaro is considered the stronger of the two when it comes to weight loss. With that said, here is where Japan's rules stand. In Japan, Mounjaro is not approved as an obesity drug. Confirm the medical indication and the safety with a clinician, and avoid deciding on your own to use it for the sake of appearance.
Is there no drug with the same ingredient meant for losing weight?
The same ingredient, tirzepatide, is handled under a different product named Zepbound as a treatment for obesity. In other words, the product called Mounjaro is a diabetes drug and nothing more. Which one to use, and how, is a conversation to have with your care team.
I hear people with diabetes find it hard to lose weight. Why is that?
Insulin resistance, the effect of the medicines themselves, and the bodily changes that come with better blood sugar all interact in a complicated way. The first is insulin resistance. The cells can no longer take up glucose, so the body secretes still more insulin. And that promotes the storage of fat. The second is the effect of the medicines. Insulin therapy, and some drugs such as the sulfonylureas, carry weight gain as a side effect in themselves. The third is a shift toward fat synthesis. As high blood sugar improves and insulin starts working again, glucose in the blood turns into fat more readily. That is why there are stretches where the weight will not come off even when you eat less.
Who tends to lose weight most easily on Mounjaro?
People with a higher degree of obesity, younger people, and those whose blood sugar was relatively low when they started tend to lose the most weight. An analysis across SURPASS-1 through 4 lists the factors that promote weight loss. A higher dose. Use alongside metformin. Being younger. Being female. And a higher BMI to begin with. There are factors working the other way too. When hemoglobin A1C, or fasting blood glucose, is very high at the start. Here is the key. The worse the hyperglycemia, the harder it is to lose weight. And patients with a higher BMI to begin with, those carrying more weight, show a steeper weight loss curve, helped along by stronger motivation to slim down.
What if the weight does not come off even with the drug?
Rather than leaning on the drug alone, sort out the causes and review diet, exercise, and illness as a whole with your care team. Step 1 is to record. Look back at your weight, how much you ate, fluids, symptoms, and whether you had any low blood sugar. Step 2 is to review daily life. Check for unbalanced meals, too little activity, sleep, and changes in stress. Step 3 is to review how you feel. Check whether the Mounjaro dose is enough, whether other medicines are having an effect, and whether another illness is behind it. Step 4 is to revise the plan. Rebuild diet, exercise, and treatment into something sustainable, together with your doctor. These 4 go round and round.
What should I talk about with my doctor at the next visit?
Share your goals, any change in how you feel, and the plan ahead with your care team. Deciding on your own is not the way. Here are 4 questions you can take straight into the appointment. 1. What are my target numbers for hemoglobin A1C and weight? 2. Which changes, gut symptoms and the like should prompt me to call? 3. How should my other medicines and my insulin dose be adjusted? 4. When is the next review, and what should I record at home?
Thank you, doctor.
Starting, increasing, combining, or stopping any medicine must follow your doctor's instructions. This material is provided for education.